Yeah, thank you very much. It's really an honor to give this keynote. And as Samudi just said, I'm going to examine whether the ethical challenges the psychedelic-assisted therapy poses to Western medicine are exceptional. And recently, there has been a debate about psychedelic exceptionalism in the literature. And an argument for psychedelic exceptionalism can be made, for example, in the following way. So first, you can say psychedelic-assisted therapy, PAT, involves unusual features. For example, there is this combination between a pharmacological and psychological intervention, and we have this psychedelic experience. These are quite unusual within medicine. Now, the second argument or premise that we can hold is that these features are actually not just unusual, they are exceptional within medicine. We do not have something comparable, for example, something comparable as a psychedelic experience in other areas of medicine or in other medical treatments. And now, because of that, due to the exceptionality of psychedelics, we should also treat psychedelics and PAT exceptionally when we look at it from a normative perspective. And now, such psychedelic exceptionalism can go both ways. So we can be exceptionally lenient or also exceptionally demanding when we look at psychedelics from an ethical perspective. So I want to look at this term exceptional a bit more closely because I think we can interpret it in two different ways. The first one is really that we think the normative standards, as they usually are, do not apply to psychedelics. So we make an exception for PAT. Either we have to treat PAT in a more demanding way, have more demanding ethical principles, or less demanding ethical principles. This I call type A psychedelic exceptionalism, and I think it cannot really be defended. So why should we have different normative standards for psychedelics compared to other medical treatments? But there's also another interpretation of exceptional, which I call type B psychedelic exceptionalism. Here, we say while the normative standards apply to PAT in the same way they apply to other treatments, they yield exceptional, unique policies because of the exceptional, unique features the PAT has, and these exceptional, unique features are ethically relevant. So these exceptional, unique features lead to ethical implications that are, to some extent, exceptional. And I think such psychedelic exceptionalism, type B, can be defended, given there are these exceptional features of psychedelics and PATs that are ethically relevant. Now, in the rest of this presentation, I want to look at 4 presumed cases of psychedelic exceptionalism: informed consent, personal psychedelic experience of therapists, study design, and enhanced vulnerability. Of course, this list is not exhaustive. There are other cases. The reason why I've chosen these 4 cases is that I have worked on these personally. So that's mainly like my view and my position, and of course, not everyone in the field shares my position. And what is also important to say when I speak of psychedelics, I mean just the classic psychedelics. So I mean psilocybin, LSD, or DMT. Okay, let's start with informed consent. There has been a paper by Smith and Sisti which kicked the whole debate about informed consent and PAT. And there they made the argument that in case of PAT, we need an enhanced informed consent process because PAT involves some unusual, unique features such as ineffability of a psychedelic experience, the potential to shift patients' values and personality, the possibility of therapeutic touch, or the presence of rare mental health risks. So we do not find these features in other psychiatric treatments, and due to that, we need to disclose them in a detailed way to patients when they are thinking about whether to undergo PAT. And this leads to an informed consent process that might be longer than what is usual in other psychiatric treatments, such as the prescription of antidepressants. But I don't think this is a case of exceptionalism, so it's just a little bit a more extended form of informed consent. That is nothing exceptional. However, we can ask the question whether, even if you have this additional information, whether you are really in a position when you get this information to make an informed decision. So if you are told, yeah, just keep in mind that if you take psychedelics, the experience will be ineffable, can you really with this information, make an informed decision whether to undergo a psychedelic experience. And the reason why there is question about that is linked to another topic that has become quite famous in philosophy, which is the topic of transformative experience. So a bit more than 10 years ago, Laurie Paul published a book, Transformative Experience, and in this book she makes the following arguments. So she says there are experiences which are transformative, and that they can be transformative in two ways. First, they can be epistemically transformative, which means that only by undergoing this experience, we learn something that we could not learn otherwise, namely what it is like. So only when you undergo, for example, a psychedelic experience, you know what it is like to be in an altered state of consciousness. You cannot really know what this is like without undergoing the experience. So that's the epistemic transformation. And there's also the potential for personal transformation. So an experience can change who we are as a person. They can change our values and our preferences. Now, both types of transformation reveal the value that an experience has for us. So we cannot really know what is the value of an experience if we do not know what it is like and if we do not know whether it changes us personally. And this is a problem for rational decision theory, because in rational decision theory, we usually need to know all the values, or at least the expected values of potential outcomes. And here we cannot do that, and therefore we cannot make a rational decision about whether to undergo a transformative experience. And now if we assume that psychedelic experiences are transformative, which many argue that they are, then we cannot rationally choose to undergo PET. Now, is this a problem for informed consent? The fact that, or the argument that we cannot rationally choose to undergo PET. Smith and Sisti already touched on this topic in their paper, and they say that we accept consent to various activities that cannot be fully imagined, for example, getting married. So even though there are options that we choose that lead to an epistemic transformation, we do not think it is questionable whether people can give informed consent to them, such as getting married. And the same is also true for experiences that have effects on personality and worldview, as for example, psychotherapy. So here we have a personal transformation. So they don't think it's actually a unique problem that we have here. However, we can put a question mark on the examples that they use. So getting married is a private decision. Maybe we have different standards in case of medical decisions, because here we are in a different context. So maybe this is not just transferable in a one-to-one way. And they mention psychotherapy, but there might be a difference between psychotherapy and PET regarding to whether the personal transformation is rather slow. So in psychotherapy, it usually takes months or even years until there is a personal transformation. And in PET, at least in theory, the personal transformation can be quite quick. So maybe, yeah, there's still some fundamental difference between PET and the examples that they use. Now, Jacobs goes into a different direction in his argument. So he buys into the whole assumptions of Paul. He also thinks that if an experience is transformative, then we cannot make a rational decision. And now for him, one function of informed consent is to promote value-aligned decision-making. And he more or less equates value-aligned decision-making with rational decision-making. And obviously this leads now to a problem. Because if we cannot make a rational decision whether to undergo PET, we can also now make a value-aligned decision and therefore have insufficient understanding of the effects of PET and the potential outcomes of PET. And therefore we cannot give informed consent. That is his argument. However, his argument is not that therefore we should also stop with PET altogether, but that we need something different. So informed consent is not possible, so we need some other ways. And this would be now an example of type A psychedelic exceptionalism, because normally informed consent is like a core principle of bioethics, and if we say, yeah, normally we have this as a core principle, but in the case of psychedelics, of PET, this principle does not apply. This would be different standards that we suddenly have just for psychedelics. Now, is the argument of Jacobs convincing? I don't think it is, for two reasons. So first of all, is it really not possible to gain an understanding of PET? I want to start here. So if a patient thinks about whether to undergo PET, they likely perceive their mental disorder that they want to treat as a deficiency that makes their life worse. So they see their current position that they are in, their status quo, as something negative. This is the very reason why they seek treatment. So that's like the starting position. Now, what does it need in order to get from this position where they are at the moment, that is negative, to a new state that is more positive and that is no longer dominated by their mental treatment? So they need a kind of personal transformation because their mental disorder has a major impact on their perspective on the world, on how they perceive themselves and others, and therefore, in order to change their perspective that is dominated by the mental disorder, they need some kind of transformative vehicle that gets them from this negative status quo to a new state that is no longer determined by the mental or co-determined by the mental disorder. And I would say preliminary evidence shows us that PET can be this transformative vehicle. And also that the risk-benefit ratio, at least for the people or the patients that are part of the studies so far, of the population groups, that the risk-benefit ratio is also acceptable. So I would say based on this, patients can make a value-aligned decision whether to undergo PET. It is not so much informed by to where PET leads them, so they do not know the exact values of potential outcomes that PET might yield, but they do know that their current status quo is negative and they do need a transformative vehicle to get into another state, and PET can provide this vehicle. Of course, not for sure, but at least potentially. So first of all, I do think we can make a value-aligned decision in the case of PET. And now I want to look at another assumption that Jacobs has, namely that even if we cannot make, or his assumption is if we cannot make a well-aligned decision, then informed consent is not possible. And I would say even if we cannot make a well-aligned decision, even if there is ignorance that prevents us from making such a decision, informed consent can still be valid. Because if we look at the role of understanding in informed consent, we see that its major function is to reduce the understanding asymmetry between the physician and the patient regarding treatment options. So the role is that it's not like this, that the physician comes and just says, look, here is all the information that I disclose, look at these 40 pages of technical language, and then you can make a decision. I recommend A. But the physician has a duty to also make this information understandable. Of course, they do not need to give a lecture about everything, but at least it has to be in some way understandable to the patient what are the pros and cons of different options, so they can make an informed, autonomous decision. Of course, this whole process also has the function that in the end, patients make a good decision. So the good decision making is not something that is completely irrelevant here. But I think it is important to note that the decision does not need to be potentially rational. But it is sufficient, so if there is irreducible ignorance, meaning, for example, the physician cannot disclose information about how exactly it will be for the patient to undergo this treatment, they cannot tell the patient exactly what will be the treatment outcome for them, what will be the value of the treatment for them. In case of such irreducible ignorance, it is sufficient if the physician just discloses this ignorance in the informed consent process. Because otherwise, if we would say that it is necessary to potentially make a rational decision in order to give informed consent, we would run into something like rational paternalism. So then rational decision-making or rational choice theory would determine whether a treatment should be available in the first place or not. And I think that would be problematic. So this whole debate about informed consent, which has sometimes been framed as psychedelic exceptionalism, I think is not. We have very similar problems in case of psychedelic treatments as in other areas of medicine. Okay, let's get to the next case, personal psychedelic experience of psychedelic therapists. So traditionally, there has been quite some agreement on the essential need for psychedelic therapists to have personal psychedelic experience. Because only personal psychedelic experience allows psychedelic therapists to properly guide patients through their own psychedelic experience, to truly understand this experience and to help them integrate it into their lives. So similar to a tour guide who needs to know their terrain, a psychedelic guide who guides a patient through the altered states of consciousness must also have familiarity with these altered states of consciousness. Otherwise, the guiding is not really working. And while here it says traditionally, so many of the people that really were proponents of this position were from the first wave of psychedelic research, we also find proponents of this position. Today, for example, Dean O'Sullivan, he's one of the health professionals granted exemptions from Canada's drug laws, and they can also use psilocybin for their own purposes to improve therapy or therapeutic processes, so to say. So Dean O'Sullivan says, it is absolutely imperative that the therapists have familiarity with the realms of the human unconscious that are visited under psychedelics, because they can help guide the patient through situations that might seem utterly bizarre and even psychotic to an untrained therapist. Now, if this is true, and if there would be a requirement for psychedelic therapists to have personal psychedelic experience, there would be indeed exceptional. So there is no other psychotropic drug where the person who administers it needs to have personal experience with this psychotropic drug. Now, how could this be justified in our normative standards? Here is a possible way. So principlism is one of the most widely shared normative standards within bioethics. And here is a possible argument how we can justify personal psychedelic experience within principlism. So the first premise is physicians have a duty of beneficence and non-maleficence. This is directly derived from principlism. Then second, policies that promote beneficence, sorry, I pronounced that wrongly, beneficence and non-maleficence can be justified by this very duty. And then third, therapist's personal psychedelic experience promotes beneficence and non-maleficence. And these two premises together lead to the conclusion that therefore a requirement for personal psychedelic experience of psychedelic therapists can be justified by this duty of beneficence and non-maleficence. Now, I think this argument, as it is here, is sound. Of course, it is still questionable, even if it can be justified. Can it truly be justified? So is it really, are like the positive effects of these policies, are they large enough to justify this requirement? But still, this would be the way to go. But now the problem is, so far there is no evidence for three. So we would really need to have studies that show that therapists with personal psychedelic experience are more effective, lead to better treatment outcomes than those without. If we would have evidence for this, then we could try, or then one could try to make this argument that therefore psychedelic therapists have a requirement to have personal psychedelic experience. But as long as this evidence is not there, I think the burden of proof for premise 3 is really on those who argue that premise 3 is correct. Because if we look at other areas where the experience of the therapist may be important, we have very mixed evidence whether this is truly the case. So to give two examples, so it could be argued that a therapist that has experience with the mental disorder being treated has also some kind of experiential knowledge that someone does not have who has never experienced this mental disorder by themselves. And this could be seen as some like epistemic advantage that they have compared to others who do not have experience with the mental disorder being treated. But if we look at the few studies that exist, that look at the question whether those that are familiar, those therapists that are familiar with the mental disorder being treated, whether they are more effective than those that are not, we do not really see an effect, even though it must be said at this point that there are just few studies. So there's no clear evidence on this question. And the same is actually true for personal therapy. So in many countries, it is mandatory for therapists to undergo personal therapy. And therapists now that underwent personal therapy also often say that this was very helpful for them. But if we look at the treatment outcomes, we do not really see a difference between those who underwent personal therapy and those that did not. Even though here too, there are not really good studies on this. So I would say for here, premise 3, the burden of proof is really on those who say premise 3 is true. And so far, there's no evidence for this. However, it is important to say that also for psychedelics, self-reports indicate that psychedelic therapists say that they benefited from their personal psychedelic experience, both personally and professionally. And also, many patients seem to prefer a psychedelic therapist with personal psychedelic experience to one without. So there's certainly a demand for therapists with personal psychedelic experience, both from the patient side and also from the therapist side. And since we administer psychedelics to healthy participants like on a daily basis, I think it's also justifiable to at least give psychedelic therapists the option to have a psychedelic experience during their training. Of course, with the same inclusion criteria as psychedelic studies with healthy participants. So I don't think personal psychedelic experience should be mandatory for psychedelic therapists, at least not with the evidence we have at the moment, but it should be optional and not forbidden. Okay, so this, if there would be evidence that personal psychedelic experience really makes the therapy better, then we would have a case for type B psychedelic exceptionalism. So far, we do not have this evidence, so this would be unjustified type B psychedelic exceptionalism. Now let's get to the next case, the study design. So in medicine, the double-blind randomized control trial is the gold standard. And it is widely believed to establish causal efficacy if the study is designed and conducted well. And the logic behind this is quite compelling. So if we can control for everything, except for, and the only difference between the treatment group and the control group is whether they are given the true substance, the real substance, or a placebo, then any effects that we measure are different between these two groups can be attributed to the placebo or the real substance. But in order that this logic really works, it is crucial that the blinding is kept up during the whole trial. And of course, this is very difficult with psychedelics. So in psychedelics, it's really it's extremely difficult to keep up blinding because the effects, the phenomenological effects of psychedelics are more or less unmissable. Interestingly, there are still many double-blind RCTs in psychedelic research. However, they hardly ever control for blinding. So they do not really ask the patients or participants whether they could discern whether they got the real substance, the true substance, the real substance, or whether they got the placebo. And the few studies that do ask patients and participants whether they think they got the placebo or not, they find that blinding was almost always unsuccessful. So this has the consequence that in case of double-blind RCTs in psychedelic research, the logic behind this design does not really work because blinding is unsuccessful. Now, in the literature, we find attempts to rescue psychedelic double-blind RCTs. And I just want to mention a few. So one attempt is to use an active placebo and not a passive one, which mimics some of the physiological effects of the psychedelic. I would still make quite a big question mark whether this truly works. So even if you can mimic some of the physiological effects, I don't think, that you can deceive many patients when they at some point realize that the psychological effects do not really kick in. So I think this is questionable whether this really works well with the blinding. Then another option or another proposal is to have a lower psychedelic dose in the control group. Here we have the problem, if the dose is really low, then it's again, quite easy to discern whether you have a high dose or a low dose. And if you have a medium dose and a high dose, then it's more difficult to discern between the two. And we also see that in empirical studies that people have difficulties, for example, to discern a medium dose of LSD and a high dose of LSD. But of course, if we have a medium dose, for example, of LSD, then we already have some therapeutic effects. So we do not compare the high dose with no treatment, but we do compare the high dose full treatment with something like half treatment or medium treatment, or how to say. So it's not really the original logic behind the double-blind RCT that we have here. Now, two other proposals are to recruit only psychedelic naive participants because they are easier to deceive. So they are not familiar with the psychedelic effects, and since they are not familiar with them, we can deceive them more easily, and they have more difficulties to guess whether they are in the treatment or in the control group. And the last proposal I want to discuss is to conceal relevant information from participants. Here, the idea is, for example, to tell everyone, so all participants and patients, that they will receive a full psychedelic dose, but actually only half of people get a full psychedelic dose, the other half gets a placebo, or they get a low dose, or they get a pre-treatment that blocks the effects of the psychedelic. Now, I think that the proposals 3 and 4 are in conflict with the principle of informed consent, and therefore are problematic from an ethical perspective. So the idea to only recruit naive participants, psychedelic naive participants, by itself is not problematic from an ethical perspective. But I guess since the idea behind that is to deceive these participants, and that they are more easily deceivable than those that are familiar with psychedelics, this must be combined with giving vague information about psychedelic effects. So in the process of informed consent, here physicians or the experimenters will likely not go into too much detail how the phenomenology of a psychedelic experience is in order to keep them in the dark about this, and so they have more difficulties to discern whether they got a psychedelic or a placebo. So I think this interferes with physicians' duty to disclose relevant information. The same is true for concealment of relevant information, obviously. So if I assume, I imagine I'm a patient and I hear about this study and I'm told that I will get a full psychedelic dose, and then afterwards I get told, yeah, actually there was some concealment, you only got a placebo. This would be very relevant for me to know before starting the whole trial, and therefore I don't think that the informed consent that was given here was really valid, because this relevant information was missing. Therefore, I say that psychedelic double-blind RCT should not be rescued by practices that conflict with normative standards. So we should not make a type A psychedelic exceptionalism case here. And just besides, like as a side note, I think that the double-blind RCT as a gold standard in PET research is questionable to begin with. So not only due to like these ethical questions, but also I don't really see how blinding can be successful in psychedelic double-blind RCTs. And like the standard RCT, how it is designed also only looks at the pharmacological intervention. So we only look if the difference between the two groups is whether they got the psychedelic or a placebo, then we only look at this, and we totally neglect the psychotherapeutic aspect of the intervention, and also potential interactions between the psychedelic and the therapy aspect. Okay, so here I also do not see a justifiable case of psychedelic exceptionalism. Now let's get to the last example, enhanced vulnerability. So in the literature, we often read something that highlights the enhanced vulnerability that comes with PET. For example, Harrison mentions the unique risks posed by the false vulnerability associated with PET. Lee et al. Note that the unique and unpredictable psychedelic experience can create situations of intensified vulnerability for some participants. Davenport et al. Write that the client-therapist relationship in PET presents greater vulnerabilities than the typical power imbalance in psychotherapy. And a paper of Manuel Traxel and myself has the title "With Great Power Comes Great Vulnerability," where we refer to the vulnerability that comes with psychedelic-assisted therapy. Okay, now in an article I try to really pin down, so where does this vulnerability come from? And I think it is connected to the impairment of autonomy that happens in three ways. So first, we have diminished decision-making capacity because on the one hand, psychedelics impair memory, cognition, executive functions. So we do not really know whether patients are still decisionally capacitated during the psychedelic experience. And we also have a change of beliefs and preferences. So we can, for example, imagine a patient who, before undergoing the psychedelic session, says they do not want to have therapeutic touch. And now, during the psychedelic session, they feel this connectedness, and then all of a sudden, for them, it's okay to have therapeutic touch. And they say, yeah, actually, I want you to hold my hand. So there is a change of preferences, and at least like in the normal decision-making capacity theories, we would assume that preferences have to be more or less stable to make a capacitated decision. Okay, so this is one impairment of autonomy. The second one is that there is limited resistance to external influences, which we see due like, for example, in case of the enhanced suggestibility and sensitivity to context, or more or less in the importance of the setting. So we are more open to external influences. Our beliefs are become more revisable, at least this is the assumption. And because of that, we cannot resist, or it is more difficult to resist influences that we would otherwise resist and that are unwanted. We become more manipulatable, so to say, which sometimes has also been exploited by some therapists, unfortunately. And the third impairment of autonomy is connected to the very psychedelic experience. So there is a loss of control of our own experience during a psychedelic experience that tends to be emotionally, and the psychedelic experience tends to be emotionally tense, turbulent, and challenging. And there is also the advice that we should not try to control the psychedelic experience. So that we should go with it, go with the flow, and also that it only in really extreme cases we should abort the psychedelic experience with some counter-medication. Okay, so of these 3 points, I think the first one is not really exceptional. We have diminished decision-making capacity often in the medical context. Then the second one might be exceptional. Maybe it's also just a question of degree. For example, we also have this potential for manipulation or something like that in psychotherapy. There we also have a revision of beliefs, but maybe it's just more, it's just accelerated in the case of psychedelics. Maybe psychedelics is really a different category. Maybe it's just a matter of degrees. We can discuss about that. But I think the third case is really something exceptional. So we do not have something similar like a psychedelic experience in other areas of medical treatment. Now, in the literature, there are proposals how to address these impairments of autonomies with safety measures. For example, Lee et al., they say we should have something like advanced directives in PET, and they mean that we should really define what is okay during a psychedelic experience and what not, and also anticipate that our preferences might change. So a patient should not only say that, yeah, I do not want to have therapeutic touch in the psychedelic experience, but also be more explicit what should happen if their preferences change during the psychedelic experience. For example, they should say, yeah, I do not want to have therapeutic touch during the psychedelic experience. However, if I change my mind during the psychedelic experience, then it is okay, but just hand-holding, for example, something like that. Or even if I change my mind during the psychedelic experience, I really do not want to have therapeutic touch. Then a second safety measure is preparatory sessions. Of course, these are standard in PET to have preparatory sessions. The one hand to prepare patients to the psychedelic experience. But another important function of these preparatory sessions is to establish a patient-therapist relationship, to get trust into the therapist, into the whole procedure, and to get a feeling whether you really want to go into this vulnerable state, psychedelic state, with this person in the room, and whether this person should really accompany you during this whole treatment. Then something else that has been proposed is that there should be the possibility for patients to have a video recording of their session, so that they have like something objective that they can look at after the session. So if they have some memory, or they remind something from the session, but they are not sure did this really happened or not, that they have this video recording and then can look it up. So this will be give them some safety. And a controversial safety measure is no psychotherapy. So Godwin made the argument that we should not put too much psychotherapy into PET, but rather just psychological support. And while this is not his main argument, he also says that if we leave psychotherapy, then we also leave the potential for malpractice that happens in the psychotherapeutic part of PET. But yeah, this is of course very controversial, this position of Godwin. Now, I also thought about a safety measure, and so far I haven't really seen that in the clinical practice, whether there is any research on that. And I do not want to say that like this solves everything, or this safety measure we should implement that immediately or something like that, but just it might be worth to put some research into that. So there has been the recommendation to bring a close person into the psychedelic session. So someone that is close to the patient. And this has actually been recommended by Megan Bousson. She experienced severe abuse in an MDMA-assisted therapy trial, which also got covered in the news. And in a podcast, she says, "The advice that I always give to people is the only way to be safe in a psychedelic space is if you bring someone with you, someone who is not tied to whoever your guide or shaman is, someone who is sober and not taking anything, and whose sole purpose in that space is to watch your back." And actually, if we look at the recreational use of psychedelics, there we see that it is very common to have like a trip sitter. And in psychedelic forums, they usually also suggest that you should have a trip sitter with whom you have a pre-existing relationship. For example, a good friend or your partner. And you should not have someone, you do not have such a relationship. So, at least in the recreational use, and here Megan Bousson, this is already quite a common suggestion to bring someone you are close to into the psychedelic, when you have a psychedelic experience. And I think also in case of psychedelic therapy, this has three main advantages. So the first one is just the fact that there is a person you are familiar with, you trust, has a positive impact on the setting as a whole. So this person is a source of security, support, confidence, and positivity during the psychedelic experience, and should improve the setting overall. And it's interesting to note that actually like a close person already plays a role in psychedelic trials, however, only after the trial ended. So usually you need someone to pick you up after the psychedelic session, which is a close person mostly. And I would suggest why not introduce the close person a little bit earlier into the whole process, because I think it can also be quite challenging for a close person when they pick the patient up and the patient has had this psychedelic experience, wants to talk about it, but they do not really understand the whole procedure and were not really involved in the whole process. So that's the first advantage. And the second advantage is connected to the whole discussion about therapeutic touch, which is really a controversial topic in the ethical literature on psychedelics. And I think if you have a close person and you discuss with this close person before whether you want therapeutic or whether if it's okay for them to touch you or for you that they touch you, then it's much less problematic if the close person performs therapeutic touch compared to a therapist. And a third advantage is, of course, that the close person can actively monitor the therapist, whether there's something strange going on. Now, this idea of bringing a close person, as I said, is just something that I would argue should be taken more into account when doing research so that we get some results on whether this is something that should be pursued more concretely or not. And it's, of course, not like the perfect solution to everything. So even if this would work, then many people do not have a close person, many people do not have a close person that they want to bring. Then even if they have a close person they want to bring, this person has to be selected very carefully because maybe there are unsolved problems between the patient and the close person, and it would be very bad if these unsolved problems suddenly appear in the psychedelic session. So this is not like the perfect solution, but still something that should be or could be researched more properly. So I think in case of enhanced vulnerability, we can make the argument for type B psychedelic exceptionalism because we need really exceptional policies to address the ethical challenges that the psychedelic experience by itself poses. Now let me conclude. As I argued, psychedelic exceptionalism can be principally be defended if there are truly exceptional features that psychedelics on PET has, and these unusual exceptional features have ethical implications. However, many presumed cases of psychedelic exceptionalism are ultimately either not exceptional and or not justified. So the informed consent debate, I would say, is not exceptional and not justified. The debate about personal psychedelic experience of psychedelic therapists, that could be exceptional, but at the moment is not justified, and the study design things are not justified as well. However, there are some cases where we can make the argument that there is type B psychedelic exceptionalism, as I did for enhanced vulnerability. Yeah, that's my presentation. Thank you.
Thank you very much, Daniel, for this fascinating overview of these issues and also some proposed solutions. We do have some time for questions and comments, so please raise your hand and will I bring the mic over? Maybe that's easiest.
Thank you, and thank you for the talk. About bringing in a close person, I work with ketamine treatment, which is not a classical psychedelic, but sometimes we bring in close persons, and it's usually a good thing, but sometimes the patient is more focused on that person, or the person that comes is like asking like, how are you? What are you experiencing? So it can be sometimes a problem as well. But with ketamine treatment, we have repeated doses, so we can talk about it for the next session. Do you have any thoughts on that aspect of bringing in a close person?
Yeah, so as I said, there are of course problems. So one problem is that the whole setting changes to like a family setting or something like that, and it's no longer individual psychotherapy that is actually taking place. I think usually in the psychedelic trials, people are lying on at least that's how it is portrayed usually, are lying on a bed and are blindfolded and listening to music. So in this case, there is not so much interaction, I guess, between the close person and the patient. That would certainly be different, for example, in case of MDMA-assisted therapy. I guess there you have more interaction during the psychedelic experience with the therapist, and then probably also with the close person. So, yeah, I I see this problem, but I would say it is less critical in case of these classical psychedelics. I'm not so sure about ketamine. And I would certainly integrate the close person also at least to some preparatory sessions. So they should also take part at least of one preparatory session, so they also get prepared to their role during the psychedelic experience. So that they not just go there and then are also very overwhelmed by the whole experience, but they are also prepared for it to some extent.
Thank you for a wonderful keynote. I had a lot of questions, but I'll stick to one. Do you see a difference whether somebody seeks the treatment themselves or is recommended by a physician or a doctor, where there's maybe some power balance and authority issues at play as well?
You mean in like regarding informed consent? Or? Well, in the end, I wouldn't, not per se. Of course, if they are pushed into the treatment by their physician, then that's, then it's kind of coercive. It's no longer a voluntary decision that they make, maybe. But if they, so the question whether they come up with PET themselves, that this could be an option, or whether their physician tells them that this could be an option for them, I don't think that makes much of a difference. But of course, in the end, they have to make their own thoughts on whether this is a good option for themselves. And yeah, I think this is the main question, not what is the source of the option, how did they get to know about it, but rather, can they make an autonomous decision, or can they make a decision by themselves in the end that is not dominated by their physician?
So if the blinding process fails, but double-blind randomized controlled trial is the gold standard for establishing causal efficacy, then how do we establish causal efficacy in case of psychedelic-assisted therapy, and how do we know they are not just placebos?
Yeah, that's a good question. So I wouldn't say that we shouldn't do double-blind RCTs at all. So I didn't want to suggest that, because, as you say, they are good to see whether there is a causal efficacy. But for me, the problem is that we have to differentiate between two questions. So one is the question: is PAT therapeutic? So does it have therapeutic effects? And I think for this, it is better to use either like randomized control trials with, for example, with the waitlist control group. So we can compare the waitlist control group with the treatment group. Or we compare it with another treatment. Carl Harris has done that in his phase 2 trial. And we compare the two treatments with each other. Then we see, is it therapeutic or not? And if we want to know what makes PAT therapeutic, I agree. In this case, we need to have double-blind RCTs. But then I would just check for one potential factor that might be therapeutic at the time. So I would say we need to look at the therapy by itself. Does the therapy has an effect on it? Then we can make dose-dependent studies to see how high the doses have an effect. And this way, if we make different double-blind RCTs, then we can get closer to an answer of whether it is of what makes it therapeutic. But we cannot make usually like the double-blind RCT design should make both. At the same time, it should tell us, is it therapeutic, and what makes it therapeutic? And I don't think this is possible in case of PET. Here we have to treat these two questions differently.
Hello. So thinking about the informed consent argument, for me it seems reliant on the assumption that psychedelic-assisted therapy is an effective treatment, but we don't really have sufficient phase 3 or long-term follow-up data. And I was wondering, as a clinician, why would it be ethical for me to prescribe this when there are other novel treatments with a much bigger evidence base?
Yeah, regarding this question, so I would say, now if we really, so to say, if we really look at it from a rational perspective, then I would say, well, if you have tried what is available and these options didn't work for you, then you need to try something new. Like you want to have this transformative treatment, psychotherapy didn't work, antidepressants didn't work, and now you're wondering, what else can I do? And in this case, you start thinking about, or you can start to think about taking psychedelics rationally, so to say. And if we then look at the preliminary results, of course, you do not have a guarantee that it will work, but still at the moment, for the populations that were studied, the chances that your situation gets much worse is rather small, and the chances that it improves are a bit bigger, I would say. Okay, you are skeptical about that, but yeah, then maybe, yeah, we have a different position here.
Thank you. I think we'll have to leave the discussion at that, but I'm sure you can find Daniel later during the conference to have a chat as well. Thank you, Daniel, once again.
Thank you.